Cardiovascular system. The cardiovascular system is composed of a four-chambered heart divided into right and left atrial, receiving, chambers and right and left ventricular, discharging, chambers. The right side of the heart, containing the right atrium and right ventricle, comprises the pulmonary circuit delivering blood to the lungs for oxygenation and release of carbon dioxide. The oxygenated blood is returned to the left side, systemic circuit, of the heart and is pumped out of the left ventricle to be distributed to the tissues of the body. The vessels constituting the cardiovascular system are arteries that originate at the heart and convey blood away from the heart. As these vessels arborize, their branches diminish in size the farther they are from the heart. Veins whose vessels return blood to the heart. The smallest vessels are farthest from the heart, and the largest vessels are closest to the heart. Capillaries, the smallest vessels with the thinnest walls, are interposed between the arterial and venous systems. They function in permitting the exchange of materials between cells and the bloodstream. Capillaries receive blood from the smallest arteries, the arterioles and metarterioles, and deliver blood to the smallest veins, the venules. Blood vessel tunics. The wall of arteries and veins is composed of three layers: tunica intima, tunica media, and tunica adventitia, Fig 11.1. The innermost layer of the tunics, the tunica intima, is composed of a simple squamous epithelium and endothelium that lines the lumen of the vessel. Interposed between the endothelium and subendothelial CT is the basement membrane in muscular arteries. The subendothelial connective tissue houses a few smooth muscle cells. The subendothelial connective tissue is surrounded by the internal elastic lamina, a perforated elastic membrane composed mostly of elastin. In cross-sections of small vessels, such as capillaries, one or two endothelial cells are able to encircle the lumen, whereas in large vessels, dozens of endothelial cells may be required to do the same. Endothelial cells provide a smooth, friction-free surface and secrete many substances, such as lamin, endothelin, types 2, 4, and V collagen, nitric oxide, NO, and von Willebrand factor, VWF. On their luminal aspect, endothelial cell membranes sport angiotensin-converting enzyme and other enzymes that incapacitate numerous blood-borne agents, such as bradykinin, thrombin, prostaglandin, and serotonin. Lipoprotein lipase binds to the luminal aspect of endothelial cell membranes and cleaves lipoproteins. The thickest of the three coats, especially in arteries, is the tunica media, composed of multiple layers of smooth muscle cells, arranged in a helical configuration. The extracellular matrix of tunica media contains elastic fibers formed by smooth muscle cells, types I and III collagen fibers, and ground substance. The outermost layer of the media, at least in large muscular arteries, houses slender elastic fibers composing the external elastic lamina. Instead of a tunica media, capillaries possess contractile cells known as pericytes. A specific protein, von Willebrand factor, VWF, which is a clotting factor, is produced by all endothelial cells. However, it is stored only within Weibel-Palade bodies of arteries. VWF facilitates the coagulation of blood as it attaches to platelets during the clotting process. Von Willebrand's disease is an inherited bleeding disorder affecting clotting of the blood. It is usually caused by deficient or defective VWF. An aneurysm is a ballooning out of the wall of an artery, or infrequently a vein, as a result of a weakness in the vessel wall. Aneurysms are usually related to aging as in atherosclerosis, or they may result from other conditions, such as Marfan syndrome, Ehlers-Danlos syndrome, or syphilis. Although aneurysms may occur in many arteries, the abdominal aorta is the most frequent site. If diagnosed in time, aneurysms may be repaired, but if an aneurysm is not discovered and it ruptures, a massive loss of blood occurs leading to death of the patient. Blood vessel tunics, cont the outermost coat, the tunica adventitia, is a fibroelastic connective tissue that affixes blood vessels to the surrounding structures, Fig 11.2. In large blood vessels, the nutrients and oxygen present in the bloodstream are unable to percolate throughout the wall of the vessel, vasa vasorum, Small arteries enter the tunica adventitia, ramify throughout the wall of the vessel, and provide nutrients and oxygen for the cells located in the adventitia and the media. Vasa vasorum are more prominent in veins than in arteries. The nerve supply of blood vessels also enters the tunica adventitia. The vasomotor nerves release the neurotransmitter norepinephrine, which diffuses to the smooth muscle cells of the tunica media. These are sympathetic vasomotor fibers that cause the smooth muscle cells to contract, and the wave of contraction is spread via gap junctions between neighboring smooth muscle cells, eliciting vasoconstriction. Arteries, Table 11.1, are large muscular blood vessels that gradually decrease in diameter as they carry blood away from the heart and deliver it into capillary beds. Although the definitions are not clear-cut, there are three categories of arteries determined by their diameter, wall thickness, and other histologic features. Elastic arteries, they are also known as conducting arteries. They have the largest diameters and are the most elastic. They have more elastic tissue than smooth muscle tissues. They have relatively thin tunica intima and tunica adventitia. They possess very thick tunica media, with about 40 to 60 concentrically arranged. Elastic tissue examples include aorta, pulmonary arteries, common carotid arteries and common iliac arteries. The abundant elastic tissues give the arteries elastic properties. That way the arteries can adjust to accommodate different blood volumes and varying blood pressures. Muscular arteries, they are also known as medium, or distributing arteries. Smooth muscle allows vessels to regulate blood supply by constricting or dilating. They possess thick tunica media to a huge layer of smooth muscle, about 25 to 40 layers. They possess thin tunica intima. They supply blood to the muscles, and the smaller muscular arteries are adapted for vasodilation and vasoconstriction. Examples include brachial and femoral arteries. Specialized arterial sensory structures. Muscular arteries house specialized sensory organs. The carotid sinus and the carotid body, and the arch of the aorta houses a similar sensory structure, the aortic body. The carotid sinus, situated in the tunica adventitia of the internal carotid artery, is innervated by cranial nerve 9, glossopharyngeal. The vasomotor center of the brain, by controlling the neural pathway, is responsible for maintaining the proper blood pressure of 91/19/60/79 mmHg, and it does so by causing the smooth muscle cells of the tunica media of blood vessels to be under a constant tonus. If blood pressure decreases, the sympathetic nervous system increases muscle contraction by releasing the neurotransmitter norepinephrine. If the blood pressure is too high, the parasympathetic nervous system decreases the tonus by releasing the neurotransmitter acetylcholine, which prompts the endothelial cells of the blood vessel to release NO. The smooth muscle cells of the tunica media relax when the NO reaches them. Regulation of arterial blood pressure, cont. The kidneys and pituitary gland control the biochemical pathways. The kidneys release the enzyme renin into the bloodstream. This enzyme cleaves circulating angiotensin O-again into angiotensin I, which is converted into angiotensin II, a powerful constrictor of tunica media smooth muscles, by angiotensin converting enzyme, present on the luminal plasma membrane of capillary endothelia. The pituitary releases the potent vasoconstrictor vasopressin, antidiuretic hormone. Blood pressure is also modulated by the presence of elastic membranes in the large, muscular arteries, but especially by the ones in the elastic arteries. As the ventricles of the heart contract, they pump a large volume of blood into the aorta and pulmonary arteries, whose walls are richly endowed with elastic fibers and elastic membranes, fenestrated membranes. The vessel wall bulges, the elastic stretches and slowly returns to its normal size, and in this way the velocity of blood flow and blood pressure are not allowed to undergo rapid changes. Capillaries. Capillaries, Fig 11.3, are the smallest blood vessels with the thinnest walls. They are composed of a simple squamous epithelium fashioned into a tube usually less than 50 gm in length and 8 to 10 gm in diameter. Where the endothelial cell meets itself, or other endothelial cells, in forming the tube, it overlaps itself and other cells forming a slight flap, the marginal fold that projects into the lumen. Endothelial cells also form fascia occludens, tight junctions. Interposed between arterioles and venules, capillaries form an anastomosing complex known as a capillary bed. Capillary endothelial cells are highly attenuated, they are less than 0.2 gm thick and their nuclei form bulges that project into the vessel's lumen. The cytoplasm possesses a scant amount of the normal organelles and intermediate filaments composed of desmin or vimentin or both. The abundance of pinocytotic vesicles associated with capillary plasmalemma is a distinguishing feature of capillaries. Capillaries form a basal lamina that coats their abluminal surface. Pericytes, contractile cells associated with capillaries and small venules, share the capillaries' basal lamina, form gap junctions with the endothelial cells, and may act to regulate blood flow. Pericytes may also function as regenerative cells that assist in repairing damaged vessels. Viewed with the electron microscope, three types of capillaries may be distinguished. Continuous capillaries are located in connective tissue, muscle, and nerve tissue, and modified continuous capillaries are located in the brain. Continuous capillaries contain numerous pinocytic vesicles, and their cell junctions are sealed with fasciae occludents, so carrier-mediated transport is required for passage of amino acids, glucose, nucleosides, and purines. Although endothelial cells regulate the blood-brain barrier, astrocytes also have been shown to exert some influence. Fenestrated capillaries located in endocrine glands, pancreas, and the intestines, possess fenestrae, pores, 60 to 80 nanometers in diameter, in their walls that are covered by a diaphragm. These pore/diaphragm complexes are situated at 50 nanometers intervals from each other, although they may be organized in clusters. Sinusoidal capillaries, located in bone marrow, spleen, liver, lymph nodes, and certain endocrine glands, are formed into amorphous channels, sinusoids, lined by endothelial cells that possess numerous large fenestrae without diaphragms. In some instances, the basal lamina and the endothelial wall may be discontinuous, facilitating a much freer exchange of materials between the blood and tissues. Vascular change. The largest arteries continue their growth to about age 25, with elastic laminae being continually added to the walls. Muscular arteries, beginning at middle age, display thickened walls with collagen and proteoglycan deposits resulting in reduced flexibility. Coronary vessels are the first to display aging signs, especially in the tunica intima. Changes are similar to those observed in arteriosclerosis. Arteriosclerosis. Arteriosclerosis is often associated with hypertension and diabetes. It is characterized by deposits of hyaline substance in the media walls of small arteries and arterioles, especially of the kidneys. Vessel rigidity results as the blood vessel walls become calcified. Atherosclerosis. Atherosclerosis is the most common cause of morbidity in vascular disease, characterized by deposits of noncellular yellowish lipid plaques, atheromas, in the intima, reducing the luminal diameter in the walls of the coronary arteries as well as in the walls of the largest arteries, example carotid arteries, and also of the large arteries of the brain. Continued deposits can reduce luminal diameter and restrict blood flow to the region involved by 25 years of age. When this restricted blood flow occurs in the coronary vessels, referred pain may be the forerunner of heart attack and stroke. Regulation of blood flow into a capillary bed. The regulation of blood flow into capillary beds is accomplished by arteriovenous anastomoses, AVA, and central channels, Fig 11.4. AVAs bypass capillary beds. Instead, there is a direct connection between the arterial and venous sides. The connecting vessel possesses three regions: an arterial end, a venous end, and an intermediate segment. The intermediate segment has a thickened tunica media and modified smooth muscle cells in the subendothelial layer and rich adrenergic and cholinergic nerve supply controlled directly by the thermoregulatory center in the brain. Blood flow is controlled by opening or closing these AVA shunts. When the AVA shunt is closed, blood flows normally through the capillary bed. When the shunt is open, blood bypasses the capillary bed. Although AVAs are located throughout the body, they are especially common in the skin, where they function in thermoregulation. Central channels are composed of a medarteriole and its continuation, the thoroughfare channel. Medarterioles, arising from arterioles, possess precapillary sphincters that, when open, allow the flow of blood into the capillary bed. Blood from the capillary beds enters the thoroughfare channels. Because these channels do not have sphincters, blood can always enter them, and from there blood is delivered into small venules. Histophysiology of Capillaries. Physiologic studies of capillary permeability showed the presence of two types of pores in the walls of capillaries, Fig 11.5 small pores, which probably represent slight gaps between epithelial cell junctions, 9 to 11 nanometers in diameter, and large pores, which probably represent fenestrated and transport vesicles, 50 to 70 nanometers in diameter. Small molecules can diffuse either through the entire thickness of the endothelial cell or through the intercellular junctions. Larger molecules are transported from the extracellular space into the lumen, or vice versa, via the use of pinocytotic vesicles, a process known as transcytosis. Other substances, such as those packaged in the Golgi apparatus of the endothelial cells, are delivered to the luminal aspect of the plasmalemma in clathrin-coated vesicles, where the cargo is exchanged for different cargo, which is transported to the abluminal aspect of the cell membrane to be released into the extracellular matrix. White blood cells leave the lumen via diapedesis. They penetrate either the endothelial cell or the endothelial cell junctions to enter the extracellular space. Frequently, diapedesis is facilitated by the presence of adhesion molecule receptors on the luminal aspect of the endothelial cells that are recognized by adhesion molecules expressed on leukocyte membranes. The pharmacologic factors histamine and bradykinin increase capillary permeability, facilitating the egress of fluid from the vessel lumen and increasing the extracellular fluid volume. If the increase in extracellular fluid is substantial, it is referred to as edema. The capillary endothelium also produce macromolecules destined for the extravascular environment, such as laminin, fibronectin, and collagen, types 2, 4, and V, substances that participate in the clotting mechanism, in the regulation of tunica media smooth muscle tone, and in diapedesis of neutrophils. Pharmacologic agents, such as the vasodilator prostacyclin, which also impedes platelet aggregation, enzymes that degrade and inactivate norepinephrine, prostaglandins, serotonin, thrombin, and bradykinin, enzymes, such as lipoprotein lipase, that cleave lipoproteins and triglycerides into glycerol and fatty acids for storage in adipocytes, and angiotensin converting enzyme that converts the weak vasoconstrictor angiotensin I to the potent vasoconstrictor angiotensin II. Veins. Capillary beds deliver their blood to venules, from which the blood drains into veins of increasing size until it enters the atria of the heart. Because veins are low-pressure blood vessels, there are more veins than arteries, and their luminal diameter is greater, such that they contain approximately 70% of the total blood volume. Veins and arteries are usually side by side, but the walls of veins are flattened because their walls are thinner, less elastic, and much less muscular. Although veins possess the same three tunics as arteries, the boundary between their tunica media and tunica intima is relatively indeterminate. The tunica media is reduced, but the tunica adventitia is increased in thickness. Veins are classified into three groups: venules, medium and small veins, and large veins, Table 11.2. To thwart the reversal of blood flow, low pressure, medium-sized veins, especially the veins of the lower extremity, possess valves that ensure a unidirectional flow of blood. Venous valves are composed of two leaflets derived from the tunica intima that project into the lumen flimsy, but are reinforced by elastic and collagen fibers derived from the tunica intima pressed against the luminal aspect of the vessel wall as blood flows toward the heart, flipped back into and blocking the lumen, like two hands cupped to hold water in the palms of the hands, resisting blood flow in the opposite direction. Varicose veins are superficial veins that have become enlarged and tortuous. Varicose veins are usually the result of aging, as the walls of the veins have degenerated, or the muscles within the vein have lost their tone, or the venous valves have become incompetent. Varicose veins may also develop in the terminal end of the esophagus, esophageal varices, and at the terminal end of the anal canal, hemorrhoids. Endocardium lines the lumen of the heart. Because it is a continuation of the tunica intima of the blood vessels, it is composed of a simple squamous epithelium, which overlays a fibroelastic connective tissue with a scattered collection of fibroblasts. A deeper layer of dense connective tissue is richly supplied with elastic fibers and intermingled with smooth muscle cells. The deepest layer, the subendocardial layer, separating the endocardium from the myocardium, is composed of loose connective tissue with blood vessels, nerve fibers, and Purkinje fibers. Myocardium. It consists of cardiac muscle. It is the principal component of the heart. It can be classified into two broad divisions. General myocardium. This is mostly concerned with atrial and ventricular contractility. Specialized myocardium. This is further divided into two, those with specialized electrical properties, pacemaker and conduction pathways, myocardial endocrine cells. These myocardial cells produce hormones, the most important of which is atrial natriuretic peptide, ANP. ANP regulates blood volume and cardiac output. Conducting system of the heart. It is composed of specialized myocardial tissue which can transmit electrical impulses. The myocardial cells are specialized for initiating impulses and conducting them rapidly through the hair. It is made up of three main components: the Sinoatrial Sa Node, atrioventricular AV node, atrioventricular bundle of his Sinoatrial Sa Node. It is located in the right atrium. Electrical impulses are generated here. It can act independently of the nervous system. It displays automaticity. Impulses are transmitted to the left atrium via a group of myocardial cells called Bachmann bundle. Specialized myocardial cells also transmit impulses from the SA node to the AV node via anterior and posterior internodal pathways. Impulses coming from the SA node to the AV node are delayed for a few milliseconds before passing it to the ventricles. This is done to avoid excitation of the atria and ventricles at the same time. Sinoatrial SA Node. The reason why the myocardial tissues of the atria and ventricles are not in contact is because there is need for spacing of their excitations and consequent contractility. The atria have to be filled and contract before the ventricles fill and contract. The only excitatory link between the atria and ventricles is the AV node, which is why it delays the electrical impulse so as to allow the entire atria to be stimulated before it passes the impulse to the ventricles, which will thereafter become stimulated. To any medical condition that distorts this mode of operation can cause dysrhythmia and consequent death of the individual. Atrioventricular AV node. It has specialized myocardial cells which slows down conduction. Thereafter it permits impulses to flow to the ventricles via the bundle of his. It is made up of specialized myocardial cells known as Purkinje cells. The Purkinje cells course on the sides of the ventricles. Purkinje cells send Purkinje fibers to the general myocardium, which then facilitates contraction of the ventricle's epicardium, representing the outermost layer of the heart. Visceral pericardium consists of the mesothelium, a simple squamous epithelium, which overlays the subepicardial layer of loose, fat-laden connective tissue with its coronary vessels, nerves, and ganglia. Enclosing the entire heart and becoming continuous with the visceral pericardium on the great vessels entering and leaving the heart is the parietal pericardium, composed of an inner serous layer and an outer fibrous layer. The pericardial cavity located between visceral and parietal pericardium contains serous fluid to reduce friction between the two surfaces of the pericardium during the movement of the heart, Fig. 11.7. The heart is the pump responsible for the circulation of blood throughout the body, and to accomplish that task it has four chambers: the two atria, which receive blood from the venous system, and the two ventricles, which propel the blood from the lymph. The extracellular tissue fluid that bathes the interstitial tissue spaces of the body, is collected by blind-ended lymphatic capillaries, Fig. 11.8, located within the connective tissue compartments and is delivered to larger and larger vessels, eventually to be returned to the cardiovascular system via the two lymphatic ducts into veins at the root of the neck. Tributaries of the lymphatic system are located throughout the body except in the central nervous system, orbit, cartilage and bone, internal ear, and epidermis. The lymphatic vascular system is an open system, lymph does not circulate, and it is not propelled by a pump. Interposed at various intervals along the roots of the lymphatic vessels are lymph nodes through which the lymph is filtered. Afferent lymphatic vessels dispense the lymph to the lymph nodes containing abundant channels lined with endothelium and copious macrophages that clear the lymph of particulate matter. As the filtered lymph exits the lymph node, lymphocytes are introduced into the lymph, which is returned to the lymphatic vessel via efferent lymphatic vessels. Heart valves. The heart valves attach to the dense irregular connective tissue that forms the fibrous skeleton of the heart. Each valve is composed of 3 layers, fibrosa. It forms the core of the valve and contains fibrous extensions from the dense irregular connective tissue of the skeletal rings of the heart. It is made of connective tissue proper spongiosa. It is made of loose connective tissue, collagen, elastic fibers interspersed with proteoglycans. It is located on the atrial side of each valve. The mitral and tricuspid, AV, valves are thin and not so strong when the ventricles contract, the aortic and pulmonary valves open, and the mitral and tricuspid valves close. This is to prevent backflow of blood into the atria. The ventricular pressure when pumping out blood is very high. It has the tendency to push the AV valves into the atria and thus send blood back into them. This situation is prevented by the attachment of tendinous cords, chordae tendinea, which are held firmly to the ventricular walls by the papillary muscles, thus preventing the valves from everting into the atrial lymphatic capillaries and vessels. The blind-ended lymphatic capillaries, formed by a highly attenuated simple squamous epithelium, possess an incomplete basal lamina, and in the absence of tight junctions intercellular spaces are commonly present between the adjoining endothelial cells. The lumina of these delicate vessels are maintained open by lymphatic anchoring filaments, 5 to 10 nanometers in diameter, that are inserted into the abluminal plasma membranes. Lymph from the lymphatic capillaries drains into small and then medium-sized lymphatic vessels whose composition is similar to small veins but with larger lumina and thinner walls. Still larger lymphatic vessels possess a thin layer of elastic fibers and smooth muscle covered by elastic fibers blending into surrounding connective tissue. The 2 largest of the lymphatic vessels, the right lymphatic duct and the thoracic duct, which empty their contents into the venous system within the neck, are similar in composition to large veins, having the 3 defined tunics and possessing nutrient vessels similar to the vasa vasorum of arteries and veins. Heart to circulate throughout the body. The 4 chambers are divided into 2 circuits, a pulmonary circuit and a systemic circuit, see Fig 11.7. Blood received from the tissues of the body enters the right atrium and passes through the right AV valve, tricuspid valve, to enter the right ventricle. Blood is discharged from the right ventricle through the semilunar valve to enter the pulmonary trunk, and from here the deoxygenated blood goes to the lungs to be oxygenated. Oxygenated blood returning from the lungs enters the left atrium, and after passing through the left AV valve, bicuspid valve, also known as the mitral valve, it enters the left ventricle. From the left ventricle, the blood is discharged through another semilunar valve to enter the aorta for distribution to the tissues of the body. Valves prevent the flow of blood back into the originating chamber mesothelium, a simple squamous epithelium, which overlays the subepicardial layer of loose, fat-laden connective tissue with its coronary vessels, nerves, and ganglia. Enclosing the entire heart and becoming continuous with the visceral pericardium on the great vessels entering and leaving the heart is the parietal pericardium, composed of an inner serous layer and an outer fibrous layer. The pericardial cavity located between visceral and parietal pericardium contains serous fluid to reduce friction between the 2 surfaces of the pericardium during the movement of the heart, Fig 11.7. The heart is the pump responsible for the circulation of blood throughout the body, and to accomplish that task it has 4 chambers: the 2 atria, which receive blood from the venous system, and the 2 ventricles, which propel the blood from the heart to circulate throughout the body. The 4 chambers are divided into 2 circuits, a pulmonary circuit and a systemic circuit, see Fig 11.7. Blood received from the tissues of the body enters the right atrium and passes through the right AV valve, tricuspid valve, to enter the right ventricle. Blood is discharged from the right ventricle through the semilunar valve to enter the pulmonary trunk, and from here the deoxygenated blood goes to the lungs to be oxygenated. Oxygenated blood returning from the lungs enters the left atrium, and after passing through the left AV valve, bicuspid valve, also known as the mitral valve, it enters the left ventricle. From the left ventricle, the blood is discharged through another semilunar valve to enter the aorta for distribution to the tissues of the body. Valves prevent the flow of blood back into the